To me, I've never understood the concept that in order for you to share your ideas, you have to pay large sums of money to a society. We do it. It's what's expected, but it doesn't have to be that way.
See, information shouldn't be costly. Information that helps people shouldn't cost anything if we can avoid that. Information should be shared. And since knowledge, the information that we have, resides all over the world, how do we make sure that we share that? How do we democratize education?
The World Society of Pediatric Ophthalmology and Strabismus is a society where all eye care professionals who are involved in children's eye care can join. This is not a conventional society where membership fee will be charged.
Every member, without paying any membership fee, has access to information about strabismus and pediatric ophthalmology.
WSPOS is moving to a new mode of communication, and we are trying to get better, to get connected all over the world.
WSPOS is a truly dynamic society which has brought together people from all walks of life, from different continents, to share knowledge, to share experiences, and more so in Africa, we have learned a lot. My African colleagues have testified to this.
Have you watched the World Society of Pediatric Ophthalmology and Strabismus webinars? They are great. Through them, we can learn, update, and share experiences with colleagues from all over the world.
These webinars are free to everyone. These webinars have been attended by people, ophthalmologists from everywhere.
So if you like the webinars, if you like the videos, if you like the educational information that WSPOS has brought to your life, if you found it important, useful, or helpful, then join me in donating to WSPOS.
That's why I donate to WSPOS.
This is why I'm donating to WSPOS.
That's why I donate to WSPOS.
I just made my donation, and I hope you can join me. Together, we can make the difference.
Your donation, however much, helps WSPOS fulfills its vision. Thank you.
Hello, everyone, all around the entire planet. My name is David Granite, and I would like to welcome you to the World Society of Pediatric Ophthalmology webinar number 16, all about amblyopia. We will be doing a 360-degree review of amblyopia, and for the first time, we have a panel of orthoptists, optometrists, PhD researcher, and the not-so-smart people, the MDs, are here with us as well. So we will cover all of it today. And already, I can tell you, we have people from all around the globe. Some are waking up like me at 6 o'clock in the morning, my time. In the Americas, Central America, South America, it is morning. In Europe, it is afternoon. In the Middle East, it is later in the afternoon. And where Lionel Koval is from, who we'll introduce in a moment, it is evening. All around the world. I think in Russia, it's all of those, if I remember correctly. So we are welcoming you from all around the globe. We are seeing every country imaginable represented. I'm seeing Nigeria, Lebanon, Brazil, Chile, Oman, my friends in the Philippines, Israel, Sri Lanka, Sweden, Indonesia, Saudi Arabia, Argentina, Colombia, the United States, Italy, France, Switzerland, Germany. It goes on, and everybody's here. We have had over 80 or 90, I think, countries now represented in the people that watched last week for our pediatric glaucoma webinar. 5,000 of you, over 5,000 of you joined us from around the world. So we appreciate that. I am going to get this started because you didn't tune in to hear from me. So let me just do a couple of quick introductions as we go. And here we are. So WSPOS is proud to bring you all of these webinars. The other webinars are live, are recorded live, and they are on our YouTube platform. Currently, we are streaming live on YouTube. We are streaming live on Facebook. We are streaming live on the Blueberry platform. You will have the opportunity to ask us questions on all of those platforms and have those sent to us. Please remember, we are doing Mentimeter. If you go to menti.com, you can use this QR code. You can use the numerical code. It's 35543. We are asking you right now where you are from so we can capture that information and we know who's joined us. We will be asking you your gender. We'll be asking you questions as we go along. We want to find out what practice patterns are around the world. And you can help us, and all of us will share knowledge and information. Please remember, we'll be sharing these Menti questions throughout today's webinar, and we want you to keep checking in on your phone or in a separate window on your computer, and we'll be telling you the results. The code again, 35543. All of your questions will be answered. Either they'll be answered live here by your panel. So this is interactive. You get a chance to change how this webinar goes by asking your questions. Any of the questions not answered live here will be compiled, given out individually to each of the panelists who will then answer them. Those answers will then be recompiled and posted on the WSPOS website. Those PDFs from the previous webinars are there now. They are phenomenal collections of information. Your questions are great and the answers are terrific. It's a great learning tool. We know around the world there are mentors that are asking their mentees to watch this as part of their training. We're hearing that from every part of the world. It's a fabulous way to help your fellows, residents, etc., learn this material. We all are learning from it. Don't forget, WSPOS is free membership, and we'll talk about more of WSPOS planning and some outstanding information that you're going to stay tuned for at the very end of the webinar. Participation certificates for those who need it can be gotten by writing WSPOS at WSPOS.org. That's WSPOS at WSPOS.org. Now, it is my pleasure to introduce our two moderators for this event. Lionel Koval really needs no introduction. I guess in these pictures, Lionel, you really are the king. As everyone knows, he's director of the Strabismus Service at the Royal Victorian Hospital. He was keynote speaker at WCPOS. He has an encyclopedic knowledge of the medical literature. We're thrilled that he's here to join us. and our other moderators, Yair Marad from Israel. He is a professor in Tel Aviv. He heads the Israel School of Orthoptics, and he's a member of our scientific committee here at WSPOS. Yair is shown here having quite a bit of fun. You'll notice that all of our panelists have fun pictures that they have included here. It is a Saturday. We are all real people, and we want you to see that we are real people. It is not just formality. We are talking to colleagues. We're not lecturing colleagues. We're engaging. And so this is who we are. This is the fun side of us, the serious side of us. Enjoy, because we are all colleagues together. Yair, I'm going to turn it over to you and Lionel to do the rest of the introductions.
Well, David, thank you very much. Lionel here. David, you and Ken started WSPOS, and we're all very grateful to you. And decades ago, you brought the world together with the Pediatric Ophthalmology Listserver, and thank you for that too. Can we have the next slide? And the speakers today are going to include Celeste Mancilla from Argentina. And next slide. Krista Kelly from Canada. And next slide. And our first speaker is Anna Horwood. I've known Anna for a long time, and I've admired her from afar and from close up. And she is the first orthoptist and the first woman to ever be the Bilchowski Lecturer of the ISA at its 2018 meeting. And she has an enormous CV, and she'll be our first speaker talking about child vision screening. Following her will be Sue Cotter, who is the optometrist who is best known to pediatric ophthalmologists. She's been part of PDIG for a long time, and we all read all your stuff very avidly, Susan, and we look forward to your talk very much. And this is the Menti code, just to refresh your memory, and we want you to click onto that. And now our first speaker is Anna Horwood. Anna?
Thank you very much. Let's get going with there we go. Thank you very much for inviting me to speak this afternoon. My talk may be a little bit different, more different from some of the other talks, because I'm talking about actually getting the screening done. So we're talking about amblyopia from a scientific point of view, but this is actually when you get out there in the middle of a rural mountain GP practice in the middle of Albania, this particular picture is. And I'll explain the public health aspect of amblyopia as opposed to the science that all of us are more used to dealing with. Where are we now? If you do a Google search on child vision and screening, you get a lot of literature. Basically, it divides into two camps. So there's people who are screening for amblyopia and low vision itself. And then the more modern literature, a lot of the US literature particularly, is talking about risk factors using photo or autorefraction. Both perfectly valid ways of going looking for amblyopia. What isn't quite so clear is how do risk factors actually relate to real cases of amblyopia? So which child with a risk factor will become amblyopic? There are very few comparative studies, and it's really difficult to compare this literature. And because of this, it's also quite difficult to work out what is called diagnostic success. Is a successful screening service a screening service that picks up amblyopia, or picks up children with general low vision, which can include refractive error, or those that have a risk factor for amblyopia? And actually, having been involved in the study that I'm going to be talking about in a minute, there is a bit of a disconnect between the literature and real-life community services. So what's actually going on the ground, what the people are taking from this literature when they're planning a local service. If we're talking about screening as such, one of the dichotomies is, do you screen once or do you do it lots of times? If you do it as a single event, you risk missing things. So if you're doing it early, you can over-refer and it can be imprecise, then you might miss things that develop later. If you do it late, then you're missing an important part of the critical period, but it's cheaper. Whereas if you do multiple tests, so a lot of countries in Europe do this, tagged along to general health screening, you detect the most severe problems really early, but perhaps some children are getting over-tested. How often do you do it? And it's expensive. And actually, how different are the outcomes from these two different models? Now, I'm using a traffic light system here to talk about good things and bad things about screening. And I'm going to use two examples. So we're going to do early photo screening of toddlers, 2 to 3 years old. So you can photorefract them early. And I'm going to compare it with a different model. If you've got a genuine problem, everything's good. You get earlier diagnosis and treatment, you get many more visits, but you do get more visits between referral and discharge, but you get more untestable and equivocal results. And once they're in the system, these children don't necessarily get discharged again until they're quite a bit older. There are quite a few false positives from photo screening, and it's an inefficient use of very expensive expert time post-referral. So the costs are loaded post-screening, and often they're not paid for by the people who are paying for the screening. But if you're in a publicly funded system, then a government is going to pay for it. And if it's a private system, then the parents are going to be paying for these extra additional costs. And again, does the better outcome justify the costs? The opposite end of this spectrum of different types of screening is the model that we've adopted in the UK, which is later referral, just one really good screen for amblyopia between 4 or 5 when children start school. It does mean that the diagnosis and treatment starts later, but it does occur promptly because we get a good diagnosis quickly. We're picking children who've genuinely got reduced vision. It's a very efficient use of expert time because you're getting fewer borderlines, false positives, and expensive visits from referral to discharge. The costs may be weighted earlier on because the screening itself is using more expensive people, might take a little bit longer, but the savings come at the end. But the question here is, does that delay cause damage to the vision or the children's development? And I don't have the answers to this. It's a debate. The Uscreen study, which is led by Herb Simons in Rotterdam, is a very large EU-funded multilateral collaboration. And we're trying to tease out some of these issues. So the countries that you see are the ones that are leading on this project. And we're looking at vision and hearing screening with a particular emphasis on cost effectiveness. And it's got 4 strands. So the first strand is that some of you listening today probably have been involved in. We're sending out massive questionnaires to as many people who will fill in the questionnaires, the country representatives who've signed up to be part of the study, collecting everything they can tell us about their national health structure, their regional differences, how many paediatric ophthalmologists they've got, how much does a school nurse cost, where tests could be done. Then there are 2 implementation studies, so one for hearing, one for vision, and the vision one, as we've set it up in Romania with partners there, starting the experience of setting up a screening service from scratch, right from talking to the government, right down to making sure that there's heating in the room that the screening's being done. And we're learning from what we've been doing in these studies. There are clever people in Rotterdam who are doing computer modelling of different scenarios. So they're preparing a model based from the questionnaires from the country reps and published data and any information that they can find, so that people will be able to tap in their national characteristics. So when do your children start school? How many paediatric ophthalmologists do you have? And you can model different scenarios. If I was to test them a year later, how many amblyopes would be missed, for instance. So that high-income countries can optimize or even perhaps disinvest in multiple screenings, and low and middle-income countries can start modeling what would happen to their money before they actually start spending it, so that they can plan and implement services. And to complement it all, we're writing a manual which is all the tips and tricks that all of us have put together about what we've learned from the implementation and the questionnaires. Basically, this is what you need to think about before you start just thinking, I'm going to buy a photo screener or I'm going to buy a load of vision tests. So it's all the practical things. The questionnaires have been very interesting. What is interesting and quite worrying is the variability in what's going on around Europe and around the world in the number of screenings, the test batteries, whether they're photo screening, doing orthoptic tests, the ages, how often they're repeating. Everything varies from country to country. People are taking different things from the literature to make their decisions. But there's a lack of, even the country representatives found great difficulty in actually accessing a lot of this data. A lot of it just isn't being published. And we're not sure how well outcomes are being tracked. They're certainly not being published. And so even if they're being collected, they're not being learnt from. And there is actually a big problem is catching what happens to the children once they've been referred, that the screening services can start to learn from. So if you look at the World Health Organization, ideally a screening program should do all of these things. We're not doing terribly well on the actually getting the evidence of these screenings. So people are doing lots of science as to which test to do, but we're not necessarily sharing the experience of how these screening services are being set up and how good they are. So everybody is having a good idea, and the publications just, in some places, there just isn't anywhere to put the publications. So it's a bit of a tip of the iceberg. The science is pretty good about which tests. There's lots and lots of literature about different screening tests and their specificity and sensitivity in certain settings, who's best to do it, and to a certain extent how much it costs. There is work going on. There's not a lot of it because it gets more difficult the more you ask these questions. What the target condition is, when to test. Do we do it early or later? How often? Do we do just one test? And the cost effectiveness. But people are working on, there is a little bit of literature on it. What isn't being looked at particularly well at all is these long-term comparative outcomes of different models of screening, because local factors are really important. And I think that's the thing that we're learning from the UScreen project, is that actually it's the people, it's the governments, it's the culture of healthcare. Do the patients agree that there's a problem, and would they follow up a referral? What is the best groundwork? And sometimes that is something that we need local knowledge, but it needs to be recorded and shared. And finally, everything needs to be followed up and audited, but there isn't really a core data set that everybody is buying into or at least sharing. So I think the take-home messages from this afternoon is definitely screening is a good thing. Definitely we should be screening. It's not clear exactly what is the best thing to go looking for. Amblyopia is a World Health Organization screening priority, but it's a little bit more debatable where the refractive error is. It's more complicated than a test sensitivity and specificity. So it's the test in the context that matters. We need to talk. And cost effectiveness does matter, because sooner or later somebody pays. And small tweaks to the groundwork actually are the things that make the differences to the numbers that come out at the other end. So maybe retraining a particular nurse affects your sensitivity. So we're learning all the time, and I hope to be able to discuss this with everybody soon. Thank you.
Anna, thank you very much. Anna, can I ask you or any other panel member if you have any experience, either practical or theoretical, with the David Hunter's Rebion or Blink gadget? Do you know what I'm talking about?
I don't have any experience. I know about it, and I don't. I mean, it's only been recently commercially available, so I've seen the pilot trials. I think it's a very interesting alternative way of looking for amblyopia. I think the argument is, or the argument that may well come from other people is amblyopia the target condition? Are we just looking for amblyopia, or are we going out looking for refractive errors, which may not be WHO? It doesn't fulfill quite as many of the tick boxes for a screenable condition, but I think we all agree that children who need glasses should get glasses. But if you're just going looking for amblyopia, then are you going to be missing the astigmates, for instance? So I think that's the question. But I think if we're screening for amblyopia, I think it's interesting and promising.
Yes, and if I may interrupt, I think that today we need to change the paradigm, the way we examine children. I think today we have many gadgets or many instruments that are really cost effective and can give us meaningful results when operated by lay people that just have a short course of doing how to do that. For instance, in Israel, we're trying to go to the kindergartens today using people that are just not optometrists or nurses, just people who are trained to do that with a photo screener. And that may be proved to be even the cheapest and the most effective way to do screening, and I hope we'll have the results in a few years.
I think my counter argument to that, and I'm playing devil's advocate here, is that yes, photo screening or automated screening is very good at picking up these children, but in some countries they don't have the infrastructure to actually receive all the referrals, or the parents don't agree there's a problem and don't take up the referral. So and I think that where the data is lacking is what happens to these children post-screening. So I've no doubt that photo screeners will pick up risk factors, but are you going to be able to find out what happens to those children? Is it better to screen them later properly in a service that's going to actually treat them all, or every country has to make a decision on that, but at the moment it's very difficult to compare different modalities, and I think that's where we need the data that isn't there at the moment.
So one comment, in San Diego, we've been running a screening program after we developed the first digital photo screener in 1999, and we screen about 20 to 25,000 children in our small city of 3 million people each year. But we also have an iMobile that has an eye care professional in it that can see the child right away. And if there's a problem, we see the children for free if they can't get care anywhere else for the backup part. But I was wondering if Sue might comment about the cultural issues, because I know you've dealt so much with that. Because we have parents that refuse to allow us to examine their child, or we have parents that don't want drops put in their kid that they have to sign off on ahead of time. We also have pediatricians that complain that even with a 90% specificity and a 90% sensitivity for a screening device, for an amblyopia, which has a low incidence, your positive predictive value is 50%. And so half the kids that come to the eye care professional end up having nothing, and they consider that concerning in terms of the cost effectiveness. Mm-hmm. So there are all these issues, but the cultural one is really interesting to me. And Sue, I know you've dealt with that.
You know, it's interesting. I dealt with that more in Chicago than I did here in Southern California. But I know what you're talking about. There's certain cultures who don't want their kids to wear glasses, and even like what Anna's talking about, even besides the cultural thing, it's a lot of these patients don't have the wherewithal or transportation or things like that to follow up, whether they don't understand, they don't have the money, they don't have the transportation. But that's always, I think, one of the biggest problems with screening is once these children are identified, can they access care? And at least in the U.S., we have many, many children who can't or don't access care, even though they may be identified with the screening. And so that's a big missing link.
I think I'm so lucky to work where I do. We in Reading, where I live, we've got a well-established screening service. We've got a 99% sensitivity and specificity. We've got what's my PPV is Oh, massive. We cover 99% of the children, 65% of the referrals come back. And although they're not tested until they're 4 to 5, but they're not, we are, in the UK, our national guidelines moved our screening recommendation from 3 to 4 in nursery schools, which not all children attend, to school entry at 4 to 5. And the outcomes from the amblyopia were no different from a couple of national audits that Helen Griffiths and Jill Carlton did, but we pick up so much more. We cover 99% of the children, and because they're not having to pay for their treatment, so many more access it. So I'm very fortunate and privileged to work in a situation where actually no child has to say they can't, or no parents have to say they can't afford to get the treatment.
But Anna, it's interesting. Anna, I'm going to be really
even
sorry,
though
but I'm going to be really curious to hear
patients who maybe can't afford treatment. That's not always the problem.
No, I agree.
And so many of them are covered under some type of insurance or public assistance, and we still, so there's a education component to it as well.
We had a problem in the Romania setting. We went around, and even the local nurses and GPs didn't really think that vision was a problem. So let alone the parents who weren't keen, but even the GPs that the nurses were going to do the screening in their surgeries, they didn't really, some of them just didn't get it. They never tested vision on any of their other patients, so why would they do the children? And it is those cultural things. It's education. Sometimes it's education that you need rather than another bit of equipment.
In the interest of time, I think we should move on. So, Susan, can you tell us about the padding amblyopia treatment studies? What have we learned? Thank you.
So, good morning from Southern California. My only disclosure is funding from the National Eye Institute, who funds the Pediatric Eye Disease Investigator Group. And my goal today is just to briefly highlight some selected findings from the amblyopia treatment studies to generate some discussion today. So this slide summarizes the results from the ATS-13 study, in which nearly 150 children who were 3 to less than 7 years of age, who had previously untreated strabismic or combined mechanism, strabismic and anisometropic amblyopia, who were provided glasses for the very first time and then followed up for 18 weeks. And we wanted to see what type of improvement in visual acuity we would have. And as you can see here, that mean improvement for the total group was 2.5 lines, with 75% of them improving at least 3 lines, and 54% of them improving at least 3 lines, and finding resolution in 1/3 of them. And resolution was either equal visual acuity or less than 1 line improvement in visual acuity. So optical treatment, this study demonstrated that there's a true treatment effect over time that occurs with wearing and optical correction. And the significance of this, in my opinion, is that if you prescribe glasses alone initially, most kids who have previously untreated amblyopia are likely to show improvement. So if you have a child who initially has 2100 amblyopia, what's going to be easier for him, to start patching at 2100 right away, or for you to do a period of optical treatment and now vision improves 3 lines, say, on average, and he's starting at 2040 or 2050. And that's obviously going to be easier for the kids starting at 2040 or 2050. So let's talk a little bit about patching dosage here. And so when we compare 2 hours versus 6 hours of prescribed patching for kids with moderate amblyopia, what we found is, on average, the same improvement. So the same improvement for 2 hours versus 6 hours of prescribed patching. And when we looked with kids who had severe amblyopia and compared full-time versus 6 hours of patching for severe amblyopia, we found similar results again. There was no difference. So in terms of dosage, I would say that full-time patching is not necessary for most kids, and shorter duration of patching may ease the implementation of treatment. And what I mean by that is, if it's just easier for prescribing something that's easier for the parent to do, then they're more likely to get it done. So in terms of guidelines, and these are only guidelines, you can certainly start with 2 hours of patching for a child with moderate amblyopia. You can start with 6 hours of patching for severe amblyopia. There's randomized clinical trial support for that. But it doesn't mean it has to be 6 hours for severe amblyopia. We have data in other studies that show 2 hours can work in many patients and work well for severe amblyopia. And of course, you can always change the dosage if you're not getting the desired effect. And atropine is an alternative. So what's some summary data on atropine? And here I'm talking about atropine 1%. Well, the pediatric studies have found that weekend drops, Saturday and Sunday, you get the same effect as if the patient is taking them on a daily basis. 80% of these kids reach their maximum visual acuity by 4 months, actually all of them by 10 months' time, and 50% of them have either equal acuity at outcome or reach at least 20/25 visual acuity in the amblyopic eye. So the other things we found out is that atropine doesn't just work for moderate amblyopia, it also works for severe amblyopia. It's also successful in older kids up to the age of 12. And the other thing is you don't have to cut plus or prescribe a plano lens for the sound eye. These kids can be in their full hyperopic refractive correction, only be blurred at near, and still do quite well on atropine. We found that atropine is well tolerated, the systemic side effects are rare, and reverse amblyopia is rare. And of interest, very interestingly, is we also found that it wasn't necessary for fixation to have to switch to the amblyopic eye for these kids to be successful. And it was not necessary as well for the amblyopic eye to have better near visual acuity than the atropinized sound eye in order to have a positive effect. So what we found with all of our studies is that atropine penalization, the treatment effect, is very similar to what we would find or what we found with 2 hours and 6 hours of prescribed patching. And you can use atropine not just for patching failures, but also it's appropriate if it's appropriate for that family as a first-line treatment. So how about older kids? I always feel people forget about the older amblyopes. So we have kids going from 7 to 17 years of age here with a wide range of acuity deficit in the amblyopic eye. And I should say that all these studies I'm talking about today, there's no deprivation amblyopia. So no deprivation amblyopes are included here. But in this study, optical correction was compared to optical correction with some part-time patching, near activities, and if you were younger than 13 years of age, atropine as well. And the outcome measure was at 24 weeks, and we were looking at how many people responded to treatment. And a responder was improving at least 2 lines, having at least 2 lines of improvement. And so you can see here that in the 7 to 12-year-old kids, in terms of active treatment, we had a nice effect. So way better in active treatment versus just optical treatment alone. However, in the 13 to 17-year-old kids, we didn't see a statistically significant difference, which I was surprised about. But what was interesting there as well was if we looked at the kids who had no prior treatment, then we were seeing the same results as we were with the younger kids. So the no prior treatment teenagers did quite well. But what I want to point out here too is if you look at the data here, these are teenagers here, and this is change in letter score. So we've got 2 lines, 3 lines, 4 lines, up to 6 lines improvement, with the blue dots here being prior treatment. There's a wide range of treatment effect here. And so even though on average they may not have done better, the teenagers, you can see that here's some kids with prior treatment who are getting 2, 3, 4 lines improvement. So the bottom line there is there's a lot of individual variability, and some of these kids do quite well. So it's not too late during the older years after 7. The rate of response could be slower, and maybe the extended recovery would be less, but they're still treatable, and there's a significant variability in response. And in my opinion, that's probably due to treatment adherence in the teenagers. And with that, I'll turn it over to the next person. Thank you very much.
Susan, thank you very much. Susan, a lot of the pediatric studies seem to finish at 14 weeks or 18 weeks. When do you finish treating these kids?
Well, very few of the pediatric studies have had the goal of looking at the best acuity that that child was going to receive. And oftentimes it related to trying new treatments and investigators having to be comfortable with if after a certain time their patients weren't doing well, they were not going to want to keep those patients on that same mode of treatment for 9 months. So that's why they're usually like 4 months in duration. But to answer your question, when do I stop treatment, is when I think the child's has the best acuity they're going to get. And for some kids, that might be by 4 months of age. But there's other kids that you might be treating 8, 9, 10 months. And so I really think, Heinel, it's so independent about the child, what type of treatment they're doing. I think adherence to treatment. But I certainly am not finished with treatment with all my patients by 4 months.
Thank you.
If I may add also, I think that it's very important to keep monitoring the vision in these patients. So sometimes you get a very good result, and then the child comes a year later and you see the amblyopia back again because it's not very easy or any other reasons. So keep monitoring the children is very, very important. And another question that came from the audience is, how do you treat very dense amblyopia? Any suggestion from the panel? For instance, if I may add my suggestion, I usually, when I have a hyperope with very dense amblyopia, I cut the glass, use a plano lens on glasses, and give atropine. And this is extremely, extremely useful. And because there's no problems with the tolerance, I have no choice to have atropine in the eye. And it's actually so useful that it's really important to keep monitoring the children, not to have a reverse amblyopia. Good eye. Other suggestions, maybe?
Yeah. So this is really interesting because the pediatric studies were done. We had data on certain approaches, but we all sort of make it up as Sue was talking with the patient in front of us. We don't know exactly how long the patient's actually doing any of it that we prescribe. Celeste, I'm wondering whether or not any of this applies in your experience in Argentina or in South America, and if any of these pediatric approaches are used, or if there's a different approach, or what might be typical for you. You have to unmute yourself.
Okay, thank you. I use like her atropine or patches, but I prefer patches because I have a lot of problem with the drops installation. Many parents put in both sides, so it's a problem. And I have better improved than atropine. But many people use atropine initially, and then when improve the vision, add patches. On many people use initially patches, and when the parents says no, pass to atropine. But I prefer patches.
And Krista, I was curious because we've heard from Anna, we heard from Sue about outcomes in amblyopia, and we keep talking about sort of acuity in the amblyopic eye. I don't want you to give away your entire talk now, but I mean, are we missing the boat? Are our outcomes wrong? And do we have reason to keep treating people over time, to look at them more binocularly and look at the brain and how we integrate and all the other skills from fine motor onward? And without giving your whole talk now, I'm just wondering if you would comment on that.
Yeah, so I'll be talking more about how we can see amblyopia as a binocular rather than monocular disorder. And I know that the goal of treatment is visual acuity improvement. And once that, when children reach their best visual acuity or normal visual acuity, then from what I understand, binocularity is not really a goal of treatment anymore. But the research that we've been doing at the Retina Foundation and also other labs have been doing as well, we're seeing that there's a lot of functional consequences that occur with children that have amblyopia, even after they've recovered normal vision. And so we're seeing like fine motor impairments, issues with walking and balance and aiming and catching. And these are more related to the binocularity impairment that we see with these kids, even after they've achieved normal visual acuity. So, yeah, so I really do think that, and I don't even know how easy it is for you to be able to try to treat that binocularity impairment, because I know that there's not a lot of, treatments out there that specifically focus just on that. But I do think that it's something that really should be focused on in the future.
Sue, we've had one question. If you can treat amblyopia up to age 17, when should you stop maintenance patching or stop following the patient?
Well, we do have some data from our that last study from 7 to 17 years of age, where we followed our 9 to 12-year-old group cohort for a year off treatment because there was concern that they would regress, like people have mentioned. And it was interesting. So they were supposed to still wear their optical correction. That was they were prescribed, whatever that was, but they had no other treatment. And we found that only 7% of them regressed, and regression was two or more lines improvement in visual or decrease in visual acuity. So that was encouraging that not very many of them regressed off treatment. And so, and I'm getting lost on the question. The question was after 17 years of age?
The question was when to stop. When do you say that the patient goodbye, I don't need to see you again? At what age? Let's say you have a 4-year-old, you treat his amblyopia, and is 20/20 in each eye. When do you say goodbye to this patient?
Well, I guess it depends what goodbye. I mean, I would still follow up that patient for routine eye care, right? So, you hope that the patient's still coming to you. When do I say I'm comfortable, I don't have to do anything more than normal following you? I don't think we really know. The regression, I want to say this. There's an awful lot of kids who have residual amblyopia, and up to 50% of them might have residual amblyopia. And I don't think we have a good feel for who is going to, the younger kids who's going to regress, who might not regress. And I think it's wise to follow these kids. And, I might start out closely following them and then have wider and wider intervals after that. I feel good about my anisommetropic amblyopes that I treat, because I feel that if they're going to continue to wear their refractive correction, I remove the amblyogenic condition. And so I feel real comfortable about them. If they've got good vision, we've treated the amblyopia, they've got stereo, I don't worry about them very much. But I do worry about my residual strabismics, who, and the younger they are, the more I worry that they might regress.
I think from a clinical point of view, that I think that often the worse the starting vision, the more likely they are to regress. And also the ones who have a lot of crowding, the ones that have a lot of, the crowding phenomenon when they muddle up letters on the row, they seem to regress. And a clinical tip that is quite useful, that if we're saving appointments, sitting them in the waiting room for half an hour with a patch on sometimes avoids going back to a patch. Sometimes they just seem to have forgotten about the perceptual learning aspect of the occlusion, the patching. So I think there is the true neurological effect going on in their visual cortex, but I think some of it is that they get used to working out what the muddle of crowding means. And I think some of that, if you're on the borderline of needing to go back to occlusion, sometimes just a few minutes, half an hour in the waiting room makes you decide, well, yeah, this child really has regressed, or they've just forgotten what the amblyopic eye could do. That's practical.
I think that's a wonderful tip, just to tell the patients, to tell the parents, put the patch on before you come to the clinic, and don't take the patch off. That's a very nice tip. Thank you.
Yeah, it is, and it avoids some heartache, because parents and kids get so despondent when they have to go back to patching, when they've done really, really well, and then they've lost a load of lines, and you have to go back.
I'm going to just grab the screen for a second and show the question from Menti. Is there an age after which you do not offer treatment for amblyopia? And as you can see, a third said there's no age at which they wouldn't offer it. And if you look, over 15 represents, it's at 75% of people. But there are still some people that use that 8 cutoff or the 12-year-old cutoff as their numbers. So that's from around the world from our Mentimeter questions.
Well, so now is probably a good time, David, to listen to Yair Morad. Yair will tell us about treating the amblyopic adult. Yair, thank you. Yair, unmute yourself.
Yeah, okay. Okay, so when do we say it's too late and we cannot actually treat you anymore? Is there a time period to say that? Well, improving vision in adults with amblyopia used to be considered a mission impossible, mainly because of the classic assumption that neuroplasticity in the visual system of adults diminishes and we cannot really make vision better. But we know that this is not true. For instance, if an amblyop patient loses the good eye, there's a good chance he will improve his vision in the amblyopic eye. And this is a study published in Lancet showing that 10% out of 254 patients actually significantly improved the vision in the good eye, in the amblyopic eye, after losing the vision. And from the PEDIG studies, we've learned that even children at the age of 17 can be improved, mainly if they were not treated before. And there's many studies that showing that patching, even this is in the lower end, you can see a study from Switzerland of patients at the average age of 32 who patched 3 hours a day and improved slightly, but significantly. The main problem was compliance. And of course, patching is not the only option today. Binocular treatments are very popular, and many people are waiting for binocular treatments to help us. Let's we're going to have a special presentation of that today. Let me just say that binocular treatment is based on the fact that both eyes are getting different stimuli, and the patient has to use the information for both eyes to actually do the task is asked to do. And only from the last 5 years, we have 8 studies in the literature, all showing improvement in vision in adults with binocular treatment. Some also used patching to improve the results a bit more. But again, the gaining of vision is limited to a very short, very minute example. Okay, perceptual learning, that is maybe one of the other answers. Perceptual learning is actually when you do a repetitive stimulus and the result is getting better results over time. Or in other words, practice makes perfect. And again, there are many studies in the last year showing perceptual learning results in adult patients with amblyopia. Many of them have shown improvement, but it's very slight. And the other problem is that many of the studies are only on a very few subjects. But one program really stands out, and that's Revital Vision Technology. Revital Vision Technology is a non-invasive patient-specific perceptual learning software that is based on visual stimulation, which I'm going to speak about shortly. And actually, the result of the studies with this software were published in very respectable journals like Nature and PNAS. And the idea behind this software is using the Gabor patch. Gabor is a Nobel Prize winner from Hungary who invented also the hologram. And he invented a specific form of stimulus that is really very sophisticated mathematically. And the good thing about it is that it yields the highest neuronal response to visual stimulus, because the shape of the patch matches perfectly the shape of the receptive fields in the visual cortex. So it yields a very high neural response. And the patent behind Revital Vision, or Neurovision as it was called, is that if you put this patch and put on both sides of it two flankers, what they call it, you get a much higher response. So the target alone gets one response, the flankers get another response, but the few of them together get a much higher response. And you can say it's like a reverse of the crowding effect. So it's a reverse crowding effect. And the other thing is that with this patch, you can actually map the specific deficiencies of each patient, because we know that amblyopic patients are not the same. Each one of them have different deficiencies in the visual cortex. And with this software, you can actually map and see where the deficiencies are, and then increase or give stimulus specifically to these deficiencies. And how it works is that the patient is first is doing some sort of screening that screens the entire visual cortex, and then the patient sits at home in front of the computer and do a 30-minute session 3 or 4 times a week, and the computer in the company base gets the information from each session and maps the responses of the patient, and actually can train each patient individually according to his deficiencies and his progress. So it's a tailor-made treatment for amblyopia, something that we don't have usually. And in the bigger study they did with this software, they examined 77 amblyopic patients with ages 9 to 55, and half of them got the treatment and half just watched the Gabor patches randomly with no order. And what they saw is that the conscious sensitivity of these patients improved dramatically, and this also improved the visual acuity. And a year later, not only that the effect was retained, they got even better. So it's a treatment that can last maybe even for life. And if you look at the results, 70% of the patients improved. Those who improved actually doubled their visual acuity, and almost half of those who improved reached vision of 20 to 25 or better, which is really nice. And some of even got vision, which is supernormal, is above 20/20. So this software is FDA approved. Actually, it's the only FDA approved software for adult amblyopia. It's in clinical practice for more than 10 years. It was invented in Israel, and in Israel we use it a lot. We also use it for low myopia, presbyopia, nystagmus, and Stargardt disease, and we got good results in these conditions also. Another option that we can use with adult patients is to use drugs. We know that levodopa-acetylcholine has some effect which actually diminishes after we stop using the drug, and that's, of course, is not clinically relevant. But if we use GABA inhibitors or serotonin reuptake inhibitors like Prozac, we get promising results. And this is a study that was published only a few months ago from England, when they had 40 patients, 20 used Prozac and patching, and 20 used patching and placebo, and they got a really nice effect of improving vision with Prozac and patching. So maybe Prozac is going to be the next drug that we're going to use. So in conclusion, treatment of amblyopia in adults is possible, and I'm glad that in the Menti questions most of you thought like this. Revital Vision is an FDA-approved software that can be used commercially and has good results. Binocular treatments show promising results, and we wait for new advances in that field. And we need to think about enhancing the treatment with pharmacological agents. Thank you.
Wow, Yair, that was terrific. Lots of stuff that I don't do, that I have to explore. Do we have any comments from any of the other speakers so far?
Yeah, Lionel, I'm wondering whether or not, since we're pediatric ophthalmologists for the most part, when an adult shows up in a general ophthalmologist's office, if they even think about this. Around the world, I'm thinking about countries where eye care is not even ubiquitous, and that it is. And Celesta, do you treat the older amblyop? Do they go to adult ophthalmologists, or are they considered that it's too late?
Again,
unmute yourself, Melissa.
I don't see adult patients. I children, but I know some. I don't know if this treatment technical. I don't use it never, because the children take orally or something like this. Is controversial because the adverse effects. I know that the adults, when they lost the better eye, they can improve because the only eye that remain had to work. So it's very important to treat adults too, but I don't do it because I don't see adults.
If I may say so, I think that brings us to the next talk. I think we have very good results with the software, with the Revital Vision, Neurovision, also in patients with nystagmus, and I have I think 20 patients at least who got driving license after using this software. So it's really amazing, because the thing is that really amblyopia is different between patients, and each patient has a different kind of amblyopia, and this software really target the specific deficiencies and treat them. Okay, any other maybe from the audience?
Well, there was a question earlier about using drugs, not Prozac, but triticoline and levodopa. I've never used triticoline. Many years ago, I used levodopa quite a lot, and I stopped using it when the pediatric study suggested that it wasn't very useful. Have you or others used those drugs?
I have not, but we do have, PEDIC does have a randomized clinical trial that compared levodopa to part-time patching, and it didn't show any benefit more than patching would, like you said, Lionel.
Lionel, I tried it for a little while in children who may have had, for example, cataracts that were treated late, and as a hope to try and open the visual system again, theoretically. I was unimpressed, and as the PEDIC data came out, it became less okay just to simply try it outside the confines of a clinical trial. So I think we should probably keep going for Lionel and Yair.
Okay, excellent. So Celeste, I think you're next. And Celeste is going to speak about amblyopia in organic disease and show us what's new on this.
Thank you. I will speak about how I'm going to treat amblyopia in organic disease. So I think that amblyopia can be considered the main enemy of pediatric ophthalmologists. People may believe a fight against tumors, retinopathy, glaucoma, and we do initially. But when we have already beaten, we must continue treating amblyopia. So any ocular disease or little children can cause it. Sorry. And when I start with tumors and orbit leads, and in orbits and leads, it is important to make diagnosis of this disease and treatment, but we can't forget to treat amblyopia too. Even hemangioma that disappear alone after any years must be treated. And in presence of congenital or secondary ptosis, we must remember that it can appear due to occlusion or astigmatism. So glasses and patches must be provided. Corneal opacities, infection leukomas, edemas, Peter disease, and others, malformations. When they are bilateral, maybe we can do corneal transplant. But in my opinion, in children younger than 5 years old, to treat with mydriatic drops, patches, and optic iridectomy is a good choice and have good results. I strongly consider that in little children with unilateral disease, a corneal transplant is a bad idea. Glaucoma can be a very difficult disease, very difficult to treat. And we can feel that we never finish with treatments, surgeries, but it's very important that we remember that glaucoma is and we must, or we should give baby glasses patches as soon as necessary. Congenital cataracts. The bilateral cataracts are easier to solve. You must perform the surgery, put or not the intraocular lenses, give glasses, and it's ready. The challenge are the unilateral one. It's very controversial if we can do intraocular lens and from whatever material. The contact can be very difficult to use and the glasses impossible. I don't insert intraocular lenses in babies less than 12 or 18 months. So if cataract size allows me, I prefer to prescribe mydriatic drops in affected eye and patches in the fellow eye, in these cases. But when the cataract don't allow me, and I can't wait the moment to insert the intraocular lens, I talk with the parents about the bad prognosis and how important visual rehab will be. From infections, macular dragging, from retinopathy of prematurity, colobomas, optic malformations, and others, we can't do anything to change it. But we can and we must prescribe the adequate glasses if are necessary and use patches early. In albino patients, I use iris print contact lenses indoor and add sunglasses outdoor. Visual stimulation can be useful too. I don't prescribe patches in these patients because of nystagmus. To conclude, the first thing we have to do is improve the organic as much as we can. In many of these cases, we will not be able to fix it, not even improve it. It's very important to prescribe appropriate or proper glasses. So we have to choose between atropine and patches. In my experience, atropine is easier to use but is much less effective than patches. Also, visual stimulation can be of great help. Finally, it's very important that parents understand and engage with treatment because we prescribe it, but they have to do it at home, otherwise it doesn't work. When there is an organic disease, we should always offer treatment, but not expect or promise great results, because many times the organic disease, we can change it. And remember, we cannot know what could happen in the future with the better eye. So we should now. Yes. Thank you.
Thank you very much, Celeste. It's what a difficult patient group you are treating. It's more difficult than my patient group. What is how can you help parents do patching on if a child rips it off all the time?
Sorry, again, please.
How can you help? What advice can you give to parents to patch a child with a monocular cataract aged 12 months? The child it's cruel treatment sometimes.
Yes, but I talk very well with the parents. I explain that it's necessary to use it, that if we can improve the vision acuity, it's better for the baby. And maybe when one eye had a bad pathology, the target is not many lines on vision, is more visual field, is light, is more light in the eye. I talk with the parents, and I talk and I convince that there are no B plan. Is the only plan the patches. And when the baby had, for example, a coloboma or something like this, I tell the mother that she must to cover the healthy eye while she is breastfeeding the baby in this moment, and speak with the baby or singing, and use this moment to improve the vision.
Yes, if I also, let's talk about how do we patch children with unilateral cataract. And what I decided eventually, and I do with all my unilateral cataract children, I tell the parents to patch the eye 6 hours a day until there are 7. What do you think? And I get very good results, visual acuity. What the panel think about that?
So you just made it, Yair, you made it up and you use it, right? And it worked. That's the practice of clinical medicine. And you know, Celeste, what you just described in the treatment of organic disease reminds me of something Rich Hurdle told me 30 years ago, and that is, in pediatric ophthalmology, a child's not blind until they're patched and blind. And that if we don't treat the amblyopia, we lose. But there is a moment and that we have gotten the best we can, and we're still trying to patch, and it turns into torture rather than patching. And I'm wondering how we all deal with the end game of, we've been patching, we've maximized the vision, there is organic disease, we're not going to likely get any further. We've done it for a month, 3 months, 6 months, whatever the decision is. And now what we're doing is just creating a family problem, a developmental problem for the child. How do we stop? Anna, when do we stop?
I try all the time, really. When the parent says it's a no with the patches, I try atropine. But in the kids in age of a school, atropine is very difficult because you can put off. You put the atropine and they can read all day, so atropine is very difficult. If I have some little improve, I maintain, I don't know, 30 minutes in a day, because in children, if you have organic disease, maybe the vision get worse again.
The rule of thumb I have is sometimes the parents tell me, you know, when I put the patch on the child, he just go to sleep. And it's just go to sleep and wait until I take the patch off. And when that happens, I usually know that that's it. We lost the battle, and there's no need to torture the child anymore. That's a good sign for me.
I have a suggestion.
Sorry.
We've recently found some success with using binocular treatment in kids that have been patching for years, that have deprivation amblyopia. It's not as big as what we see with other types of amblyopia, but it could be another option, down the road if they're done with patching or they're sick of patching.
Mm-hmm. Yeah, I agree. I had a child who really refused to patch, and he went to do a binocular treatment, and I was amazed how he really advanced. And that brings us to your talk, Krista.
Yes. I think it's important to think about the psychological factor that the parents haven't failed. Everybody's tried their best. It's just that it hasn't worked for that particular child. So even for milder levels of amblyopia, you sort of have to flip from going, your child has a problem, you need to wear a patch all the time, to actually, there are worse things than an amblyopic eye of 0.4. You're saying, well, this eye has a normal visual field, it has normal color and motion perception, it's a useful eye. And that's quite a difficult flip to do for the not the pathology, but the sort of ordinary amblyopic child, that you're having to say, well, you've all tried our best, it's mucking up your lives, perhaps it's time to stop. But it's, there are worse things than an amblyopic eye as well, which is quite a difficult thing to get over sometimes. Because we don't want them to go away feeling that they've been a failure because they haven't managed to inflict what is a torture on their child for some kind. So we need to say that everybody does their best and it's time to stop. But you just need to get the consent, and you have to get the agreement with everybody, I think.
David, isn't it illegal in America to inflict cruel and inhumane punishment on someone?
Well, yeah, the Western world, when we had people that needed cruel and inhumane punishment, sent them to Australia.
Yes.
Well, but there are a lot of parents that want to use video games and virtual reality and use all these different techniques and technologies, and it may turn out that they've been right all along. And I'm excited to hear what Krista's going to have to say.
Krista, I think it's your turn now. Thank you.
Thank you.
And Krista's talk is called Seeing and Treating Amblyopia as a Binocular Disorder.
Okay, well, thanks for inviting me in this conversation today. So traditionally, amblyopia has been treated as a monocular disorder. Patching can be effective, but about 40% of children fail to achieve normal visual acuity, and of those that do, 19 to 50% will regress. Normal binocularity is rarely restored, and this might be because patching does not force the eyes to work together. In normal visual development, the eyes need to send equal input to the brain so that connections can form that combine this information together. And if you have a misaligned or a blurry eye, you can have the visual acuity deficit, but you also get a host of binocular deficits like nil or impaired stereo acuity, intraocular suppression, and also fellow eye deficits for tasks like slow reading and fine motor impairments. Several groups have found that if you decrease the fellow eye contrast, you can actually reduce the suppression in the amblyopic eye, suggesting that these individuals have a structurally intact binocular visual system. And based on this research, there has been, I would like to say, an explosion of treatments looking at binocular treatments for amblyopia. And what I want to focus on here is the stuff that we've been doing at the Retina Foundation for several years, looking at rebalancing the contrast between the two eyes. And there have been many iterations of games and movies and cartoons with this, but I just wanted to focus on the one that I've been a part of, which is a dichoptic game. And with this game, children take it home. They wear red-green glasses that separate the images between the two eyes. The amblyopic eye will see the high contrast red images, so the minors here, and the fellow eye will see the low contrast blue images like the cart and the gold. then the contrast in the fellow eye will increase every day with successful gameplay. And the key to this treatment is that both eyes need to work together to be able to play the game. And here are data from a randomized clinical trial comparing this game to patching. And just after 2 weeks, we found that the game improved vision by 1.5 lines, and this was double what we found for patching, suggesting that even in the short term, binocular game treatment may be better than patching. Then at the 4-week visit, we found 40% of children, almost 40%, recovered normal vision. So this is just results from one of the studies that we've been doing, but over the years, all of the studies that we've had pretty much give us the same results, where we see 1 to 2 lines of improvement with 2 to 4 weeks of treatment, and a lot of children recovering normal vision. And more recently, we've been seeing that there are improvements in binocular outcomes with this sort of treatment, where we see mild improvements in rand-dot stereoacuity and reduced intraocular suppression. So this suggests that contrast rebalancing binocular treatment may also help with the binocularity impairment that we see in amblyopia. So apart from the stuff that we've been doing at the Retina Foundation, there have been several randomized clinical trials evaluating the contrast rebalancing approach. And I've kind of just put them all on the table right here because there are some things that I wanted to point out. One is that, we see really good vision improvements in the studies that we do that don't really translate into the clinical trials that have been done with the multi-center clinical trials. And I just wanted to point out a few differences so that you can kind of, see for yourself whether or not you think that binocular treatment might work in these kids. So first off, the studies that we do, children are enrolled and they are much younger than the other studies. So we don't enroll children over 10 years of age. And 25% of the kids that we enroll are older than 7. We also have a lot of children that come to us as their first line of defense. So a lot of children have had no prior patching. Further, most of the children that we test have, they're orthotropic. So only 21% of the kids that come in have a misalignment, and that's a small misalignment of 1 to 4 prism diopters. Now, with all the other studies, there was a significant improvement for most of them from baseline. The only issue is that they didn't see a superiority over the comparison group that they had of control, glasses, or patching. And the reasons why this might be is because a lot of the studies had much older participants, some enrolling adults, and a lot of them had prior patching treatment and larger misalignments. And the main thing that I want to point out is if you have older patients that have been patching for months or even years, they may have intractable amblyopia, and regardless of what treatment you give them, they may not improve anyway. So this is just kind of the differences between some of the studies to give you an idea of what might be happening for those ones that don't really show great results. And as I mentioned before, there's huge interest now in binocular treatment for amblyopia. The contrast rebalancing approach is just one of many. We see multiple methods of binocular treatment using virtual reality, iPad, tablets, or games or movies. And they manipulate different aspects of the treatment as well, where they change the contrast or the luminance, use perceptual learning, like the Gabor patches, push-pull methods, and some are also implementing 3D elements into the treatment. So this is just to show you that there is a huge desire to be able to find an alternative treatment for amblyopia rather than just patching. And so I just kind of wanted to say that I do think that binocular treatment is a promising additional option for treating amblyopia. And my question to you is whether or not you think that binocular treatment should be implemented in the clinic, and if so, how? And further, touching on Dr. Goodnett's question earlier, once you achieve normal visual acuity with treatment, how do you treat the remaining binocularity impairment, now knowing that there are functional consequences that come along with that binocularity impairment, like fine motor problems? And that's it. Thank you.
Thank you, Krista. I think binocular treatment is the way to go in the future because in my experience in the binocular treatment that I had in my clinic, first of all, the kids really love it, and it's really much more fun to treat a child that asks the parents to start the treatment rather than run away when the parents approaches him with a patch. And so that's a good option. What do you think, David, Lionel?
Yeah, so I mean, I think it's crucial. I think that we've ignored this for a long time. I mean, the patch is maybe 2,000 years old, and our new treatment, atropine, came around 300 years ago. So, it's really nice to have something that's a modern treatment. Krista, I was curious if you've done anything that looks at the brain, is from PET scanning to functional MRI to BOLD or any other techniques. Is there something that we're changing in the brain that's different when we use isolated monocular treatment versus binocular treatment?
That is not something that I've looked at, but I think that there have been a couple of groups that do show that if you rebalance the contrast between the two eyes, that you get a difference in what happens in the brain. I'd have to really go through and look at that. But, I've been really interested in maybe looking at that at some point, with functional neuroimaging. Can you see any difference in activation once you reduce that contrast in the brain? And I know that there are some studies that have looked at, one study looked at if you if you reduce the contrast in the fellow eye while doing binocular fixation, that fixation stability gets better. So that shows that there is definitely something going on in the brain when you rebalance the contrast between the two eyes.
And Anna, the first people to teach me anything about this field were orthoptists. Phacoder filters have been around for a long time. I mean, were orthoptists right all along?
As I understand it, Krista, most of these dichoptic methods are limited to fairly either straight eyes or small angle deviations. Otherwise, you can't use the kit. And I can't see that there's any disadvantage in doing this because those patients probably have peripheral fusion in the first place. They've got straight eyes. Something's keeping their eyes locked straight. I am a bit concerned about if there are any developments that start using them in haploscopic devices that correct the angle of deviation in a strabismic child, then are you then going to be able to achieve binocular? They're going to have surgery. It's going to have to be very accurate. It looks to me as if the dichoptic treatment in straight-eyed children are achieving their best potential normal binocular vision. In the small angle deviations, you're reinforcing abnormal retinal correspondence in that small angle deviation, both of which are useful and valuable things. I'm a little bit concerned about people not investigating the characteristics of the suppression, and particularly in squints that have been there for a very long time, because, for instance, infantile esotropia seems to be a response to absence of binocularity. They didn't have binocular vision in the first place, which is probably why they started to become esotropic. Those children probably don't have the sort of peripheral fusion potential that the straighter eyes children do. So I think it's really exciting, all these methods that can be used, but I think we need to be very careful about moving straight on to larger angle strabismus.
Yeah.
So, sorry, go ahead, Krista.
I was just going to say, with the studies that we do have, we've recently looked to see if being orthotropic or not makes a difference. And even the kids that have like 1 to 4 prism diopters don't do as well. And I do agree that, we don't enroll anybody over 4 prism diopters because we agree that you don't want to, create that abnormal retinal correspondence.
I have to say as an orthoptist that although intractable diplopia is a very slight risk for most people having treatment for amblyopia, I think those who have been around long enough don't like to risk inducing intractable diplopia. So I think we need to have some sort of way of monitoring. I mean, the old-fashioned Bagolini filter bar is the sort of best orthoptic test that I know, but it's not very good. So I'm sure there are much better ways of assessing it digitally that we could do. But it's an exciting method, but I think we need to hark back to some of the the things that were old-fashioned when I was learning, that people told me, we did this, we over-treated these children and they didn't do well. And I think there are some people who have those skills are no longer alive.
Sue, I wanted to ask Sue this question because it's somewhat controversial, and what the heck? Optometrists and ophthalmologists have looked at some of these things differently, and optometry raised functional issues from things like bimotor skills or reading or sports performance or other things that went along with amblyopia treatment way before ophthalmology did. Is this, the binocular treatment, something that you think is more likely to catch on in the optometric world, or be brought to parents' attention now, where we say to them, not only will your child not see in one eye, but maybe their bimotor skills aren't good? I mean, where do we go with this, and what does this imply for practice?
Well, in terms of binocular vision and suppression, it's interesting. Everybody says, oh, this is this newfangled idea, but optometry's been doing it for years. So if you go back in the optometric literature, we've always treated suppression. Now, not every optometrist is the same, but I've always done optical correction, get as much improvement as I can with patching. And for my anti-symmetropic amblyopes, I would do anti-suppression therapy once I hit the wall with my patching. And so the idea was, I was taught that they still have some suppression, and what you need to do is eliminate that suppression. So I might take a 2100 amblyope, bring them down to 2040, 2032, and then I would do active vision therapy, which was anti-suppression therapy for that. So it's kind of old news for optometry. The thing that's new news is that it's the technology. We were using red-green filters, and, it was very low tech in terms of things we did. Pens, red pens that would cancel with red filters for activities. But I'd like to re-emphasize what Anna said, and that is, everybody gets excited about the technology, and I think practitioners want to just start prescribing this type of therapy for all their amblyopes. And I worry too, like Anna does, that if you've got a strabismic amblyopia, you need to place those targets at the angle of strabismus and then be able to, if you break down that suppression, take it the rest of the way in terms of treatment. You have to be prepared to do that. And so I don't worry about my anti-symmetropic amblyopes, but I do worry about strabismics.
Sorry, if I may add, I think that one of the other advantages of binocular treatment is that we have monitoring of the compliance. Because if you're dealing with a computer, we know exactly how many hours did the child actually do the therapy, which we never know with patching. We can only guess, and can only, I guess that the parents always are exaggerating by at least 30% of the time that they patch. But Krista, can I ask you, do you see really different results in terms of improvement of binocularity with the binocular treatments as opposed to patching?
We have found mild improvements. Stereo acuity is a lot harder to improve, I think, with the binocular treatment, particularly because it's not a 3D treatment. It's 2D, and there's no 3D elements to it. But we do see big improvements with suppression. From that one study that I compared it to patching, I don't think that I saw a difference between the two in terms of the improvement in suppression. And I mean, that's not a bad thing. Patching still works, and binocular treatment seems to still work, and it can be an additional option. But I do think that the treatments may need to be tweaked a little bit to be able to get that, to be able to get real improvement in stereo acuity.
The stereo acuity depends on you having disparity tuned binocular cells in your cortex, and they really develop in those first 4 months of life, and it's how much of that can you get back. So suppression may be a different mechanism, but you do have to have these fine tunings of specific cells, and whether you can treat that, I don't know. So that might explain the difference in your results.
I think Larry Tyson taught us all that early surgery gives better results, and I think, and that was Eileen Birch's work showed that as well. Krista, I'm a co-investigator of the Bravo group that was number 5 on your list of poor results from binocular treatment. And you only mentioned the adults in that group, but the children in that group also didn't do well. And,
right. And sorry, go ahead.
No, and I approached this with so much enthusiasm and was very disappointed in the outcome.
Right. I think one of the main reasons why Bravo didn't really see a great result was the game itself, Tetris. Tetris, I mean, it's nothing like what kids are playing these days. And I know that the compliance wasn't that great. And if you don't have kids playing the game, how can they be getting treatment?
Yes, I agree completely. I think at the time it seemed to be really good, but when you have old people like me choosing a game for 8-year-olds, well, we didn't do it well.
Well, it was the only one that was made at the time.
Well, this has been an unbelievable discussion, and unfortunately, our 90 minutes are up. We have never had this many questions come on all the platforms we have had for this session, and so obviously we've spurred discussion. And we're ending with where we start, which is in amblyopia, getting families and children to comply may still be the biggest issue that we all have to deal with. A couple of things that I want to share with everybody, because we have some exciting information that we want to go forward as we wrap up. And the first is the Worldwide Connect will be it's not the virtual World Congress. The World Congress will be shifted. This is a new event that will take place Saturday, the 26th of September, as we connect with the world. Essentially, if you give us 24 hours, and we will give you the world. So what we mean by that is this will start in Australia and work its way around India, and then into Europe, and then into the Americas, as we go 24 hours straight of educational material. You're allowed to sleep during parts of it, but it's going to be a phenomenal event as the sun rises and sets around the world. The cost is going to be below what some people keep when they cancel their meetings, 75 euros for those who use euros, and then 50 euros for nurses, orthoptists, optometrists, allied healthcare workers, and those who come from the World Health Organization list of developing countries. So it's very reasonably priced, and we're looking forward to seeing everybody joining us for an incredible 24 hours of expertise being shared. And the patient will come first. It will be patient-oriented in its discussion. Remember, subscribe on our YouTube page if you want to make sure that you don't miss anything. Join on the Facebook page. There are thousands of people now discussing cases. We will have Grand Rounds cases. WSPOS Grand Rounds cases are coming up. In 2 weeks, we will have a myopia session that will look for the webinar. We're going to take our first week off. We have done 16 webinars in a row, 16 weeks in a row, and this will be our first week off. It's going to be very exciting to come back and talk to you about myopia. And then after that, we'll be doing the WSPOS Grand Rounds cases. We'll be looking for you to submit cases. Look out for that from around the world. I think I misspoke earlier when I said it was the WHO countries. I meant the UN countries, of course, that are represented for the lower fees. And that'll all work itself out for the WSPOS Connect. All your questions will be answered, the ones that we could not get to live, and there were more questions than we've ever had before. They will be sent out to our panel whose job is not over, and they will be archived on the WSPOS website. They will be, membership in WSPOS is free, so don't be worried. Just join for free and become a part of WSPOS, a global movement. And WSPOS is a charity. And I want everyone to recall that. Membership is free and the organization is a charity. If you need a participation certificate, Remember to go to WSPOS at WSPOS.org, WSPOS at WSPOS.org. Send an email and you'll be able to get that as well. Thanks to NTOD who have hosted these sessions. Thanks to Revital Vision for their support. Thanks to Darren McCafferty for his help. And there was one other. Oh, yes. Thank you to Akila Acharya for her help as well. Without them, none of this happens. And most importantly, I want to thank our panel for their expertise, their willingness to share, their global thoughts. Celesta, I know you're speaking not in your primary language, and thank you for putting up with our English and fast talking. And thank you from around the world, where for Lionel, it's already Sunday, I believe, and the rest of the world may be getting started. With that, we'll exit, and once again, look forward to seeing you again in 2 weeks. Thank you all from the bottom of my heart for all of your effort, and we appreciate it. See you all soon as we exit this group now. Take care. Bye-bye.
Bye-bye.
I think we have a video from the sponsor.
Bye-bye.
Yes. Yes, as we exit, Yair will introduce this video from...
Few body organs are as complex and delicate as the human brain. That's why science is increasingly committed to unraveling its mysteries. Up to the 1950s, the adult brain was thought to be hardwired with fixed and immutable neuronal circuits. The discoveries made so far as to how the brain grows and develops are surprising and astounding. Current research shows that the brain is plastic and dynamic, and that its development can be traced not only to the neurological substrate, but also to the quantity and quality of stimuli resulting from functional demand. This plastic property of the central nervous system is referred to as neuroplasticity, the underlying structural changes brought about in response to a wide range of experiences. Each new learning experience forces the brain to reorganize itself, forming new connections. These new experiences become embedded in the memory of the individual. Image quality depends both on the input received through the eye and on the processing that takes place in the visual cortex. Based on this new concept of neuroplasticity, a new treatment was devised: visual perceptual learning. It relies on visual stimulation and the improvement of neural connections responsible for vision. The software package we used was Neurovision Correction Technology. Neurovision uses an internet-based, computer-generated visual training exercise regimen using sets of patient-specific stimuli based on Gabor patches to sharpen contrast sensitivity and visual acuity, as described by Pollitt and Saji. The science behind Neurovision is one of neuroadaptation, which promotes special interaction between specific neurons. Neurovision was approved by the FDA in 2001 for the treatment of amblyopia, till then deemed irreversible. Clinical trials have since been underway for cases of myopia, presbyopia, and post-refractive surgery. Improvement in visual function and permanent results have led us to broaden its use to patients with post-cataract surgery with multifocal IOL, Restor Plus 4, post-interstromal corneal rings, and retinal degeneration. The equipment used in measuring visual acuity and contrast sensitivity was the Optec 6500. Studies have shown that patients with Restor Plus 4 implants report good, uncorrected far and near visual acuity. However, improvement in intermediate vision did not meet expectation in some cases, and there was a reduction in contrast sensitivity. So, we decided to use Neurovision correction technology in 5 patients with Restor Plus 4 IOL implant. They underwent a total of 20 sessions in a 5-week period. Uncorrected visual acuity improved from 20/25 -2 to 20/20, while intermediate visual acuity went from 20/40 to 20/30. Contrast sensitivity after treatment was within the normal range. Patients also reported decreased glare and improved night vision. Patients were quite pleased at the end of the treatment. Patients with keratoconus who have intrastromal implants usually complain of impaired night vision and glare, in spite of improved best-corrected visual acuity. After Neurovision, best-corrected visual acuity went from 20/30 -2 to 20/25. Look at the remarkable improvement in quality of vision. On examining a patient with pigmentary retinosis, we noted that best-corrected visual acuity in photopic conditions was 20/30, and in mesopic conditions, 20/50. Thus, confirming the difficulty these patients have in seeing at night. After 23 sessions, visual acuity in mesopic conditions improved from 20/50 to 20/25. Greater contrast sensitivity and improved night vision made activities such as driving and strolling at night a lot safer. The results obtained so far have been encouraging. Mean visual acuity, contrast sensitivity, and main functional outcome have all improved significantly for the cases we assessed. Further studies with larger samples and longer follow-up periods are necessary to replicate the results obtained. The breakthrough aspect of visual perceptual learning was the fact that visual complaints requiring complex resolution were minimized through the creation of new connections and as yet uncharted pathways within the visual cortex. This promising new technique represents a conceptual shift in the approach to several eye diseases. Today, the key to improving visual function lies in our addressing the brain as well as the eye. One further step in mankind's continuous quest to a better life.